If you have been taking a blood pressure pill every single morning for the past year, Amlodipine, Losartan, or Lisinopril, how confident are you that you truly understand what that pill is doing inside your body right now? Not what the label says, not the one sentence your pharmacist printed on the bag, but actually understand it, the way it works, the way it can quietly turn on you under the right conditions, and the warning signs that separate a minor inconvenience from a situation that requires urgent medical attention. These are not weak medications. These are not vitamins. Amlodipine, Losartan, and Lisinopril are powerful drugs that change how your heart, blood vessels, and kidneys function every single day. And yet millions of seniors take them on autopilot with very little understanding of what to watch for, what to avoid, or when something that feels ordinary is actually a signal your body is desperately trying to send. Understanding the three medications, they are not the same. Amlodipine, Losartan, and Lisinopril all lower blood pressure. That is where the similarity ends. They work through completely different biological mechanisms. They have different side effect profiles, and they require different things from you as a patient. Amlodipine is a calcium channel blocker. It works by relaxing the walls of your blood vessels, specifically the smooth muscle inside arteries, so blood flows with less resistance. It does this by blocking calcium from entering the muscle cells of your artery walls. Calcium is what causes those muscles to contract. By blocking it, the muscles relax, the arteries widen, and pressure drops. This is a direct mechanical effect on your blood vessels. Lisinopril is an ACE inhibitor. ACE stands for angiotensin converting enzyme. This enzyme is responsible for converting a hormone called angiotensin 1 into angiotensin 2. Angiotensin 2 is one of the most powerful vasoconstrictors in your body. It tightens blood vessels and raises pressure. Lisinopril blocks that enzyme, so less angiotensin 2 is produced, blood vessels stay relaxed, and pressure comes down. Losartan is an ARB, which stands for angiotensin receptor blocker. It works at a similar step in that same system, but through a slightly different door. Instead of blocking the production of angiotensin 2, Losartan blocks the receptors that angiotensin 2 binds to. The hormone is still there, but it cannot dock onto the vessel wall and cause constriction. The result is the same, lower pressure, but the mechanism is different enough that the side effect profiles differ meaningfully. 3 different mechanisms, 3 different side effect profiles, 3 different things to watch for. The name on your bottle is not just a label, it is a category, and the category tells you the pattern. Amlodipine, leg swelling, and what it really means. One of the most widely misunderstood side effects in all of blood pressure medicine is the swelling that affects a significant percentage of people taking amlodipine. Depending on the dose, studies suggest that anywhere from 10% to 30% of patients experience some degree of peripheral edema, swelling in the feet, ankles, and lower legs. Here is what actually happens, explained simply. When amlodipine relaxes the small arteries in your legs, blood flows in more freely. The arterioles, the tiny vessels that deliver blood to your tissues, dilate, but the veins, which are responsible for carrying blood back up to the heart, do not relax in the same way. Veins have less smooth muscle than arteries, so they are less affected by calcium channel blockers. The result is an imbalance. More blood coming into the lower legs than going out. Pressure builds up in those tiny vessels near your ankles and feet. That pressure eventually pushes fluid out of the vessels and into the surrounding tissue, a process called capillary filtration. The result? Puffy ankles, socks that leave deep indentations, shoes that stop fitting, legs that feel heavy and full by late afternoon. The swelling tends to be worse at the end of the day because gravity has been pulling fluid downward all day. It is often better in the morning after lying flat overnight. This is not fluid retention from eating too much salt, your kidneys failing, or heart failure starting. In most cases, it is a predictable physiological response to how amlodipine works. It is a mechanical issue, more fluid entering the tissue than leaving, not a sign that your heart is weakening or your kidneys are shutting down. The dangerous part, not the swelling itself, but how people respond to it. Some people see the swelling and stop the medication without telling anyone. Their blood pressure climbs back up quietly, often over weeks or months, and they have no idea they are now walking around with uncontrolled hypertension. Others keep taking the medication but start avoiding water because they believe they are retaining fluid. That is the wrong direction entirely. Dehydration on a calcium channel blocker carries its own risks. When you are dehydrated, your blood volume drops, which can make your blood pressure fall too low. And low blood pressure in an older adult can cause dizziness, falls, and kidney strain. Some people simply endure it in silence for months, reducing their activity level, assuming the worst, and losing quality of life unnecessarily. They stop walking, they stop standing for long periods, they avoid social situations because their feet hurt or their shoes do not fit. All of this happens while they quietly worry that something more serious is wrong. The right move, leg swelling on amlodipine, is a conversation your doctor needs to know about, not because the drug is necessarily wrong for you, but because there are adjustments, alternatives, and strategies that make it far more manageable. Possible strategies include elevating the legs for 20 to 30 minutes in the afternoon to help fluid return to the heart. Compression socks that gently squeeze the lower legs and prevent fluid from pooling. Reducing the dose, sometimes a lower dose of amlodipine is enough to control blood pressure without causing significant swelling. Switching to a different calcium channel blocker, some are less likely to cause edema than others. Adding a second medication, sometimes a small dose of an ACE inhibitor, or ARB, is added alongside amlodipine. These medications dilate veins as well as arteries, which helps balance the inflow and outflow. All of these are options, but none of them happen if you suffer in silence. Lisinopril, the cough and the emergency. The most notorious side effect in the ACE inhibitor family, which includes lisinopril, enalapril, and ramipril, is the cough. Not a wet cough, not a productive cough. A dry, scratchy, relentless tickle in the back of your throat that tends to be worse at night and does not respond to cough drops, lozenges, antihistamines, or anything else in your medicine cabinet. Here is the mechanism. ACE inhibitors block the enzyme that converts angiotensin 1 to angiotensin 2, but that same enzyme, ACE, also breaks down a substance called bradykinin. Bradykinin is a peptide that causes blood vessels to dilate and promotes inflammation. When you block ACE, bradykinin levels rise, and in some people, elevated bradykinin irritates the airways and triggers a persistent cough. The cough is not a sign that your lungs are damaged. It is not a sign that the medication is failing. It is a sign that your body is sensitive to bradykinin accumulation. Here is what makes this one so tricky. It often does not start immediately. Some people develop it within the first week. Some take 3 or 4 months before the cough appears. By that point, the connection to lisinopril never even crosses their mind. They have been on the medication for months without issue, so they blame dust, allergies, a lingering irritation after a cold, or acid reflux. The cough can persist for weeks or months. Some people develop it so gradually that they do not even remember when it started. They just know they have had a tickle in their throat for a long time. They mention it to their doctor in passing, but because it is not painful or alarming, it often gets overlooked. When the connection is finally made and the medication is switched to Losartan, which targets a similar mechanism but does not cause bradykinin accumulation, the tickle in the throat is often gone within 2 weeks. 2 weeks of relief after months or even years of a nuisance cough. Angioedema, a medical emergency. There is a symptom in the ACE inhibitor category that is not a nuisance. It is a medical emergency. If you are on lisinopril and you develop swelling of your lips, tongue, face, or throat, especially if swallowing or breathing becomes difficult, you do not wait. You do not call the office tomorrow. You do not take Benadryl and see what happens. You call emergency services immediately. This is a condition called angioedema. It is rare, affecting roughly 0.1% to 0.7% of people taking ACE inhibitors, but it is real, and it can close your airway faster than you expect. The mechanism is the same bradykinin accumulation that causes the cough, but in a smaller subset of people, the bradykinin levels get high enough to cause significant swelling in the deeper layers of the skin and mucous membranes. The swelling can progress rapidly. What starts as a tingling sensation in the lips can become difficulty breathing within minutes. A dry cough is a nuisance. Throat swelling is an emergency. The gap between those two things is important. Additional side effects of lisinopril include a metallic taste in the mouth, dizziness, and in some cases, a rash. These are less common but worth noting. The metallic taste is harmless but can be unpleasant. The dizziness is typically related to the blood pressure lowering effect and may improve as your body adjusts. Losartan, potassium, salt substitutes, and hidden dangers. Losartan, like lisinopril, works on the renin-angiotensin system, the body's blood pressure regulation pathway. One of the effects of this class of medication, both ACE inhibitors and ARBs, is that they can raise potassium levels in the blood. They do this by reducing the excretion of potassium through the kidneys. Aldosterone, a hormone that promotes potassium excretion, is suppressed when you block the renin-angiotensin system. Less aldosterone means more potassium stays in your blood. For most people, this stays within a safe range when monitored appropriately, but add certain common lifestyle choices on top of it, and the picture changes dramatically. Potassium does not just come from bananas or supplements. It is hiding in products that are actively marketed as the healthier choice. Salt substitutes. Many popular low-sodium salt alternatives, the ones sold right next to regular table salt and often branded as heart healthy, Replace sodium with potassium chloride. A single teaspoon of some salt substitutes can contain as much as 1,500 to 2,000 milligrams of potassium. To put that in perspective, the daily recommended intake for most adults is around 2,600 to 3,400 milligrams. So, a senior who has been told to cut back on salt buys a potassium-based substitute, uses it liberally on every meal, and is now loading potassium into their system while taking a medication that already raises potassium levels. The combination can push potassium high enough to affect the electrical system of the heart. What makes it dangerous, high potassium, a condition called hyperkalemia, does not always scream at you. It sometimes announces itself quietly as unusual muscle weakness, persistent fatigue, a cramping sensation in the legs, tingling in the hands or feet, or a fluttering, irregular heartbeat. Sometimes there are almost no symptoms at all, right up until there are serious ones. Severe hyperkalemia can cause cardiac arrhythmias that are life-threatening. Other hidden sources of potassium, electrolyte powders, and sports recovery drinks. Many are marketed for hydration, but contain significant amounts of potassium. A single serving can have 300 to 600 milligrams. Meal replacement shakes. Some contain added potassium to support muscle function. Coconut water. A popular natural hydration source, but 1 cup can have over 600 milligrams of potassium. Certain herbal supplements. Some teas and supplements are formulated with potassium-rich herbs and can add to your total load. The practical approach: if you take Losartan or Lisinopril and have switched to a salt substitute in the last year or two, or if you regularly use any of the products mentioned, this is a conversation that needs to happen with your doctor. Not because you need to panic, not because these products are inherently bad, but because the combination of medication and dietary potassium without awareness and monitoring can create a slow-building problem that never needed to happen. Your doctor can order a simple blood test to check your potassium level. If it is elevated, the solution might be as simple as switching to a different salt substitute, reducing your use of potassium-rich products, or adjusting your medication dose. These are straightforward fixes, but they only happen if you bring it up. Illness changes the rules. The sick day plan. One scenario that does not get nearly enough attention in conversations about blood pressure medications. What happens to these drugs when you get sick? Not a serious illness, not hospitalization, just a bad stomach bug, a few days of vomiting, diarrhea that will not quit, loss of appetite for a couple of days, or simply a hot week in summer with heavy sweating and not enough fluid intake. When you are dehydrated for any reason, the same dose of Losartan or Lisinopril that was perfectly calibrated for a well-hydrated body can act dramatically differently. Your blood pressure can fall too low. Your kidneys, which are already working harder due to the fluid loss, become more vulnerable. Dizziness, weakness, faintness, or acute kidney strain can develop faster than most people expect. Here is why. These medications, particularly ACE inhibitors and ARBs, work partly by reducing the pressure inside your kidneys. In a healthy, well-hydrated state, this is beneficial because it protects the kidneys from high-pressure damage. But in a dehydrated state, there is already less blood flow to the kidneys. Add a medication that further reduces that pressure, and you can cross a threshold where the kidneys are not receiving enough blood to function properly. The medication did not change. Your body's internal environment changed, and the drug is now operating in conditions it was not designed for. The practical takeaway: illness changes the rules. You should have a plan from your prescribing doctor for what to do when illness hits, whether to hold a dose, when to call the doctor, what symptoms should trigger a visit. If you do not have it, ask at your next appointment. What should I do with my blood pressure medication if I get a stomach virus or cannot keep food and fluids down? Some doctors will advise holding the medication until you are rehydrated. Others will advise reducing the dose. Some will say to continue as normal but monitor your blood pressure more frequently. The right answer depends on your specific health history, your other medications, and your kidney function. But the point is that you should have an answer before you ever need it. NSAIDs and kidney risk, a common overlooked danger. Here is a scenario that plays out in thousands of households every single day. You have a bad week, your arthritis flares up, your knees are aching, your back is stiff. You head to the drugstore and pick up ibuprofen, something you have used for years, something from the shelf that anyone can buy. It is familiar, it is cheap, it is effective. You do not think twice. Now you are taking Lisinopril or Losartan. Maybe you are also on a diuretic, a water pill for extra fluid management. This combination, when used regularly, can meaningfully reduce blood flow to your kidneys. In the context of even mild dehydration, the risk of kidney injury rises substantially. The mechanism: NSAIDs like ibuprofen, naproxen, and diclofenac block the production of prostaglandins. Prostaglandins are compounds that help dilate the small arteries that supply blood to your kidneys. When you block prostaglandins, those arteries constrict, reducing blood flow to the kidneys. ACE inhibitors and ARBs also affect kidney blood flow. They reduce the pressure inside the kidney's filtering units, which is usually protective, but in the context of reduced blood flow, it can become problematic. Add a diuretic, which reduces fluid volume, and you have 3 different mechanisms all pushing in the same direction. Less blood flow to the kidneys. This is not a hypothetical rare scenario. It is one of the most common, most preventable situations seen in clinical practice. Patients do not think of ibuprofen, naproxen, or similar over-the-counter anti-inflammatory medications as real medications in the same category as prescriptions. They are just something from the drugstore, something for the pain. But your kidneys do not distinguish between prescription and over-the-counter products. They respond to chemistry. The risk is highest in older adults because kidney function naturally declines with age, in people with pre-existing kidney disease or diabetes, in people taking diuretics, during hot weather or illness when dehydration is more likely, with prolonged use, days or weeks rather than a single dose. The safer alternatives, acetaminophen, Tylenol, is generally considered safer for the kidneys. It does not affect the prostaglandin system and is a reasonable choice for mild to moderate pain. Topical anti-inflammatories like diclofenac gel or capsaicin cream deliver the medication directly to the painful joint without significant systemic absorption, reducing kidney exposure. Physical therapy, gentle stretching, heat, and cold therapy can all help manage joint pain without medication. In some cases, a different prescription medication may be appropriate. If you routinely use anti-inflammatory pain medications for arthritis, joint pain, or back pain, and you take any of these 3 blood pressure drugs, have that conversation with your doctor. You do not have to simply endure the pain, and you do not have to silently accept the risk. There is usually a better path. You just need someone to help you find it. Dizziness and fall risk, the underreported danger. For many seniors on blood pressure medications, dizziness when standing up is a regular experience, and it is almost universally underreported because it seems too minor to mention. It happens when you stand up from the couch, get out of bed in the morning, or stand up after a meal. The world tilts for a second. You grab the door frame. It passes. You go about your day thinking, I just got up too fast. In older adults, a few seconds of dizziness is enough to cause a fall. A fall is enough to cause a fracture. A fracture, particularly a hip fracture, can derail an older adult's health trajectory in ways that take years to recover from, if recovery happens at all. Hip fractures carry a 12-month mortality rate of 20% to 30% in the elderly population. Many survivors never regain their previous level of mobility or independence. The mechanism: the dizziness happens because your blood pressure medications are doing their job, lowering blood pressure. When you stand up quickly, gravity pulls blood toward your lower body. Normally, your cardiovascular system compensates almost instantly. Your blood vessels constrict, your heart rate increases, and blood pressure stays stable. But in older adults, and especially in those taking blood pressure medications, this compensation is slower and less effective. Blood pressure briefly drops. Blood flow to the brain momentarily decreases. You feel it as a lightheaded, tilting sensation. The fix is often simple. Rise slowly. Count to 5 before you stand. Sit on the edge of the bed for a moment before standing. Let your body adjust. Hold on to something stable, a wall, a countertop, a piece of furniture when getting up. Give your body a few extra seconds to catch up with the change in position. Stay hydrated. Dehydration makes orthostatic hypotension, the medical term for this phenomenon, significantly worse. Beyond the practical adjustments, dizziness that happens regularly, dizziness that does not improve after the first few weeks on a medication or an episode of near fainting are signals that deserve a real conversation. The dose may need adjustment. The combination of medications may need review. Something in your hydration habits may need to change. Your doctor may be able to switch you to a different medication that has a gentler effect on postural blood pressure. They may adjust your dosing schedule so that you are taking the medication at a time when it is less likely to cause dizziness. Silence on this issue is not a small risk. Every fall you avoid is a hip fracture, a hospital stay, or a loss of independence you never have to experience. Blood pressure monitoring: patterns, not panic. Blood pressure is not a fixed number. It moves constantly throughout every hour of every day in response to dozens of variables. How well you slept, whether you had caffeine, if you're in pain, whether you're anxious about the reading itself, whether you just walked in from outside, whether you spoke loudly right before sitting down. A single high reading on a random Tuesday morning after poor sleep does not mean your medication is failing. A single low reading after you have been dehydrated on a hot day does not mean your medication is too strong. What matters is the pattern over time, measured consistently. The correct way to monitor: use the same arm every time. Measure at the same time of day, preferably in the morning before eating or taking medication. Sit quietly for at least 5 minutes before measuring. Do not rush into it. Keep your feet flat on the floor. Do not cross your legs. Support your arm at heart level. Do not hold it up yourself. Do not talk during the measurement. Take 2 readings 1 minute apart and average them. Write down the results, including the date and time. When people monitor inconsistently and react emotionally to individual readings, the decisions that follow are almost never good ones. Extra doses taken out of fear, skipped doses because one reading looked good, frantic calls to the doctor about a number that in context was completely unremarkable. The approach: monitor with a method, track over time, bring the log to your appointment, let patterns, not panic, guide the conversation. That simple shift reduces anxiety, improves decisions, and gives your doctor far more useful information than a single alarming screenshot from your home monitor. Final summary. These medications work through a steady, consistent presence in your system, not spikes and gaps, not extra doses when you're worried, and not skipped doses when you feel fine. Amlodipine, Losartan, and Lisinopril are not rescue medications. They are not designed to be taken reactively like a pain reliever after a headache appears. Amlodipine relaxes arteries by blocking calcium. Watch for leg swelling. It is a mechanical effect, not heart failure. If swelling occurs, talk to your doctor. There are many strategies to manage it. Do not stop the medication abruptly. That can cause a dangerous rebound spike in blood pressure. Do not restrict fluids. Dehydration on this medication is risky. Lisinopril blocks the enzyme that produces angiotensin II. Watch for a dry, tickling cough. It is a nuisance, not dangerous. If the cough is persistent, switching to Losartan often resolves it within 2 weeks. Swelling of the lips, tongue, face, or throat is a medical emergency. Call 911 immediately. A metallic taste in the mouth is less common but harmless. Losartan blocks the receptors that angiotensin II binds to. Watch for potassium levels, especially if you use salt substitutes, electrolyte powders, or sports drinks. If you have switched to a potassium-based salt substitute, tell your doctor. A simple blood test can check your potassium level. Across all 3 medications, illness and dehydration change how these drugs work. Have a sick day plan from your doctor. NSAIDs like ibuprofen and naproxen increase kidney risk. Use them sparingly and talk to your doctor about safer alternatives. Dizziness is a fall risk. Rise slowly, hold on to something, and report persistent episodes to your doctor. Monitor blood pressure consistently and look for patterns, not single readings. Do not adjust your dose without talking to your doctor. These medications require steady, consistent levels to work safely. Understanding your medication is not just about being informed, it is about being safe. It is about knowing what to watch for, what to avoid, and when to ask for help. It is about taking an active role in your own health rather than simply swallowing a pill every morning and hoping for the best. Your blood pressure medication is a tool. It is a powerful tool, and like any powerful tool, it works best when you understand how to use it properly. The information you have now gives you that understanding. Use it to have better conversations with your doctor. Use it to recognize warning signs early. Use it to stay confident, capable, and in control of your health. Subscribe for more evidence-based health information.